Thank you, Dr. Ravi, and thank you, Natasha. Now we have all seen a newer aspect of keratoconus. Let's go to diagnosing it in a clinic. So, diagnosis is mainly based on imaging. So, in this presentation, I'm going to tell you about the elevation-based topography, which will include a slit scanning devices and fluid-based devices. We'll touch upon one or two slides on biomechanics, and lastly, aberrations, aberrometry associated in keratoconus. Coming to slit scanning devices, the slit scanning devices that we use is the OBSCAN. A typical OBSCAN would have an anterior elevation map, posterior elevation map, pachymetry map, and a curvature map with a central statistical data. In keratoconus, you are likely to find that the posterior floor difference would be more than 0.050. You will have irregularity which will be more, and in 3 and 5 millimeter zone it will be more than 1.5 and more than 2.5 respectively. You will also see that the thinnest cornea, the thinnest point would be 20 microns less or more less than the central pachymetry, and this point may lie outside the 3 millimeter zone. Also, the K max would be invariably more than 48 diopters. When you compare the other eye, you are likely to find difference in astigmatism of more than 1 diopter. Coming to the shine plug imaging, these are all the single shine plug based devices. They have a single shine plug camera, and of late there is a dual shine plug camera also, which is the Galileo. So this is a typical pentacam printout. So you will have anterior sagittal curvature, anterior elevation, posterior elevation, and pachymetry map with the statistical data on the left side. So in keratoconus, you are likely to find that the K values will be on a higher side, more than 45, 46. Then you will have inferior irregular steepening. When you look at the interior elevation, you will have some points or number of points which will be more than 12 microns. So this should raise a suspicion that we are dealing with some disease cornea. The posterior elevation, which is the most important part, would be more than 18. The range is between 18 and 22 depending on the ethnicity. And you'll have a thinnest corneal thickness which would be around 500 or less than 500, and all these points would be coincidenting with the thinnest pachymetry point. The pentacam also gives us the Bellin-Ambrosi display. In keratoconus, you are likely to find that the cornea has an abnormal facial profile, which is PTI and the CPSP, and you'll have D values which would invariably be more than 2.60. You will have abnormal difference maps of the anterior and the posterior, which will be shown, the difference would be shown on the bottom left side. So these are the single shine plug devices. Now of late a newer shine plug device, and it has been increasingly used, which is the Galileo. It gives the concept of best fit toric A sphere. What the concept says that it's a referential surface, and it conforms to the disease cornea much better, and it gives you a truer indices, which needs to be validated. Through this BFTA, one is able to find out posterior asphericity asymmetry index, which is simple summation of the maximum elevation and maximum depression irrespective of the sign, and it should be less than 21.5. It also gives us the probability indices in keratoconus, which can be looked at as a reference. So this is the only part which says that what we have dealt with is the imaging. Now what next? How to measure the strength of the cornea? We know that there is weakening of the cornea, but how much weakening? Do you know that? How much weakening? Do you have a objective assessment of that? So objective assessment can be done using a ORA, which is the ocular response analyzer, or Corvus XT. When I was in Narayana Netralaya, I worked a lot on the Corvus XT. So in keratoconus, what you find that there is a significant increase in the deformation amplitude. So the deformation amplitude is the distance between the cornea traveling from the 0 point to the maximum depression head. The more stiff the cornea, the less it would deform. The more weak the cornea, the more it will deform. And there will be significant increase in corneal oscillation. This modality has been used extensively to study the effect of collagen cross-linking in cornea. What happens in collagen cross-linking? People say that it becomes stiff. How stiff? How much stiff? So it is seen that once the cornea becomes stiffer, the deformation amplitude decreases. So let's apply this knowledge. So you have a patient that walks into your clinic with a thinnest corneal thickness of 502 microns and refractive error of minus 4.25. and the patient says that I want to get the LASIK. You see the posterior elevation is normal. This is where we stop and we see that this is normal and we can operate. But no, when we look at the biomechanics, we find that deformation amplitude given here is 1.27. That means it moved 1.27 millimeters on the air puff when we did a Corvus. In our study, we have found that any value more than 1.1 should be looked at suspicion. So 1.27 and a 500 micron, 502 micron cornea. Would you like to do anything? So, no, I would not like to do anything. So let's look at another example. So this is a pentacam of a patient. All the points look normal to me except that the interior keratometry and the interior zygomatic curvature, you see a little bit of asymmetry. You look at the difference map is clean. But when you look at the Corvus, the deformation amplitude is 1.29. So 1.29, I would like you to see the thickness. Can you see 529, 530? So this much thickness, do you expect the cornea to be too weak this week? So we don't expect that. So it's better to observe these patients. So you have told patient has walked in, you have told him that I can't do LASIK, I will not be able to do LASIK. Now patient says I am having keratoconus, I have diagnosed keratoconus. But ultimately the patient wants that I want to have good vision. And he's still not achieving good vision. So what are we missing here? So most of the time we just ignore these subtle things, which are the aberrations. See, in aberrations, what happens in keratoconus, it's a highly aberrated eye. The cornea plays havoc with the visual quality, the aberrations play havoc with the visual quality, and they cannot be improved with spectacles. Contact lenses can significantly improve the visual quality and the quality of life. So the most common aberrations that are commonly associated in the lower order is the astigmatism, and in higher order is the vertical coma and the trefoil. So how do you objectively, you have told the signs to the patient doesn't agree with you. Patient says, I don't care, you just tell me how to do it. How do you measure aberrations? You can measure aberrations by using any of the aberrometry techniques. You can use ray tracing, you can use dynamic skiascopy, or you can use a double pass technique. So what happens? Once you put in a contact lens, so this is a patient without a contact lens, and you see the scatter. The scatter is measured by the OSI, which is the optical scatter index. The optical scatter index is measuring that how much when a point of light is entering a visual system, it is getting scattered. So in a keratoconus, this is a point of light and it is getting so much scattered. You put an RGP, this point becomes a little bit a point source. Eye is not a perfect system, you cannot achieve a zero scatter. So OSI of less than 1 is considered normal. From 6, the patient has come to 1.4 and you are able to explain that this is the visual quality he will achieve after having contact lenses. I don't think you can lose your patient. Now take home message, you should remember the important points for the diagnosis and follow-up. It is better to follow up the patient if there is any suspicion. Use your biomechanical aspect to follow up the patient, that's very important. And keratoconic eyes, you should know that have higher degree of aberrations and poor visual quality even after best correction. It's better to incorporate multiple imaging practice if you can. Thank you so much, and all the images that I've used are courtesy of Dr. Rohit and the team, and you also have that in your booklet, and you have a 5-point nomogram which Dr. Rohit is going to talk about. Thank you so much.